Session here. In this video, I'll be discussing about the concepts related to asthma, and I'll be discussing about the concepts related to Croup, epiglottitis, and cystic fibrosis. So last part in the respiratory. So let me read the points written here. A classification of asthma according to severity. It's written that you have a steps, symptoms, nighttime symptoms, and you have peak expiratory flow. And we got a different steps here, right? We have in all these aspects. So let us understand them. So what is asthma? Asthma is it's nothing but it's a respiratory condition where there are attacks of spasm in the bronchi. You got an attacks here, so there is difficulty in breathing. So because of spasm in the bronchi, because of some allergic reaction, you have that vasoconstriction, bronchoconstriction. So that leads to a difficulty in breathing. So now let us classify the babies under or depending on the symptoms. So when do we call it as an intermittent asthma, or mild persistent asthma, or moderate persistent, or severe persistent? So we have under this intermittent, that means when do we call as intermittent asthma? Normally this classification of asthma, it is according to the severity. So if you look at the first thing, intermittent, we have symptoms less than one time a week, right? You should have a symptom less than one time a week. And if it is asymptomatic and normal, right? Asymptomatic, normal. And if PEFR, right? If we have got a normal PEFR between the attacks. So let us understand what is it trying to tell us in these aspects. If a child has less than one time a week, if they attack, right, the bronchoconstriction, if they attack, if the asthma attack, if it is less than one time in a week, we call it as intermittent asthma, right? And if the person has a normal PEFR, what is PEFR? PEFR, it's nothing but it is a peak expiratory flow rate. So what does it mean? Suppose if you draw a graph here, whenever you exhale air, this is the exhalation and this is the inspiration. This is a normal graph. And the maximum speed of expiration and this part, and this is known as PEFR, that is peak expiratory flow rate. So now if you look at the peak expiratory flow rate between the attacks, right? If this is the first attack and this is a second attack, between the attacks, the how much the force or the speed of expiration, that is PEFR, peak expiratory flow rate, if it is normal, right? And we call it as intermittent asthma, right? Or the patient is asymptomatic, right? If you look at the nighttime symptoms, if the nighttime symptoms or the nighttime asthmatic attack, if it is less than 2 times a month. So in the night times, in the first, we consider as months here, less than 2 times a month. So this child is known as intermittent, right? This child is intermittent asthmatic. And if you look at this peak expiratory flow rate, the peak expiratory flow rate, that is these guys have more than or equal to 80% predicted, or variability less than 20%. So what do you mean by variability? How do we calculate variability? Variability of PEFR is calculated as PEFR at night, that is peak expiratory flow rate at night, minus peak expiratory flow rate at morning, by half of PEFR at night plus PEFR at morning into 100. So whenever you calculate this, whenever you put the values here, you get a variability, and this is known as PEFR variability. If the variability is less than 20%, right, variability is less than 20%, or the predictor value of the PEFR is more than or equal to 80%, and these guys or these children comes under the intermittent asthma. So these are the important points, guys, we have to understand under the intermittent. Just understand that the attack should be less, that means less than one time a week. If it is a night time, less than 2 times a month, or if you look at the normal PEFR between the attacks, it should be normal. And if you look at the PEFR flow rate, it should be more than or equal to 80%. That means now you should have, if it is more than normal, this is what out of 100%, if it is more than or equal to 80% of predicted values, right, and he can exhale well, so there is less very less bronchoconstriction. So that is the reason you're gonna get a good amount of air when you are exhaling out. So more than or equal to 80% is predicted, and the variability is nothing but peak expiratory flow rate at night by minus peak expiratory flow rate at morning by half of peak expiratory flow rate at night plus peak expiratory flow rate at morning into 100, and if the variability is less than 20. And now you understood the basic concepts. So let's go with the second step. Second, in the sense, when do we call as mild persistent? And now if the attack is more than one time a week, if you observe carefully here, the intermittent less than one time a week, but as the severity increases, next will be the mild persistent. In this mild persistent, more than one time a week, but less than one time a day, right? But less than one time a day, right? More than one time a week, but less than one time a day. If it is less than one time a day, more than one time a week, and these children comes under the mild persistent. If you look at the nighttime symptoms, now it bit increased, that is more than 2 times a month, we call it as mild persistent. And if this peak expiratory flow rate, if it is more than or equal to 80% of predicted, but now the variability has increased 20 to 30%. If this peak variability, the value is 20 to 30%, and we call it as intermittent, mild persistent. Next we have moderate persistent. In this moderate, who are the guys known as moderate persistent? Moderate persistent are the guys who use these beta agonist daily. That means they use daily use of beta 2 agonist. Why they use daily? Because there are daily attacks. So that's what you have to understand here. You can just understand MO for morning. You have daily morning, right? Morning. So MO, daily use of beta 2 agonist. That means daily attacks. And if you look at this, now the night times, now from the months it has shifted to weeks. There are more than one time a week, we call them as moderate persistent asthmatic attack. And if you look at these persons where this PEFR value is more than 60% and less than 80% of predicted, and the variability of PEFR, now it has increased more than 30%. So as the severity increases, the variability also increases, but the PEFR predicted value decreases, right? As the severity increases, the episodes during the night increases. As the severity increases, the episode or the symptoms also increases. If you look at the step 4 will be the severe persistent. So what do you mean by severe persistent? Where the symptoms are continuous, right? And because of these continuous symptoms, and this guy has got limited physical activities, right? And nighttime symptoms, it's frequent. And if you look at the PEFR is less than or equal to 60% predicted, and the variability PEFR is more than 30%. So these are the important points we should understand. The intermittent type, or the step 2 type, step 3 and step 4. We got a question here, and that tells us a nighttime symptoms. So if you look at these nighttime symptoms, a child has a nighttime symptoms more than 2 per week. So more than 2 per week, if you look at these, and this will be an persistent, because moderate persistent, because in the moderate persistent it is more than one time a week, more than one is 2, so the answer will be moderate persistent. So this guy who has a nighttime symptoms of more than 2 times a week, and he comes under the moderate persistent conditions, right? So these are the things, guys, we have to understand regarding this aspect, regarding the severe, all this. So let's go with the next point. The next will be the treatment. So what is a treatment? We know what intermittent, we know what is mild persistent, we know moderate persistent and severe persistent. So let's go with the treatment. Intermittent persistent. So if you look at these intermittent persistent, we're gonna give short acting beta agonist, right, as required for symptom relief, right? So for the symptom relief, when because now the attack, right? If the attack is, that means if you look at this, the attack, it is less than one time a week and less than 2 months, so we have got a less symptoms there. So we're gonna use a beta agonist, and that too short beta agonist. And for what are we gonna give this? We're gonna give to, it is required for symptom relief. And if the person has got a mild persistent, right, a mild persistent, so we know that in the mild persistent, less than what, 2 times or more than 2 times in a month, or more than 1 time in a week, right? These children are known as mild persistent. In these children, we're gonna give inhaled steroids, right? We're gonna give inhaled corticosteroids, the steroids, so that we can reduce the symptoms, like what, beclomethasone and fluticasone, right? Fluticasone, beclomethasone, we're gonna give this for the mild persistent. If you look at the moderate persistent, for the moderate persistent, we're gonna use this salmeterol, right? We're gonna use salmeterol, that is a long acting, right, long acting beta agonist. Along with this, we're gonna use what, montelukast, because now the symptoms are more than one per week, night times, and we can look at these moderate guys daily use of beta agonist. So we're gonna use a long term acting one, that is salmeterol, that is a long term. And we're gonna use montelukast. What is that montelukast? You know that you got an leukotrienes which are increased in the asthma, that can lead to a problematic, that means that can lead to symptoms. So we're going to block that leukotrienes. For that, we're going to use montelukast. Next, we have something known as severe persistent. So what is severe persistent? Severe persistent, where you have a frequent attacks at the night, and the continuous limited physical continuous, you got to have a continuous attack and limited physical activities. In this condition, these guys are known as severe persistent, where we're going to use an oral prednisolone, right? We're going to use this oral prednisolone, right? So in these oral prednisolone, we're going to use them long term. It's a long term. We're going to use them on an alternate days, right? We're going to use this oral prednisolone, and we're going to use them as a low dose alternate days for the long term. So this is the treatment written here regarding this treatment of asthma, that is intermittent mild persistent, right? If you look at this, as the severity increases, we're going to use that, increase the drug also. So if you look at this intermittent, we just use the short acting here. But if here in the mild, inhaled steroids we used, and we're going to use in the moderate long acting, and in the severe we have used the alternate oral prednisolone. So as the severity increases, if this child do not cure by these drugs, so we're going to increase the drugs. So that's all you have to understand. In detail, we already spoke in the medicine respiratory. So if you look at the next one written here, it's written that fever and stridor, and that means there is some upper respiratory upper airway obstruction. And it's also written that we have something known as infective causes of stridor. Under this we have laryngotracheal bronchitis, Croup. Under this it's written 75% para-influenza, prodrome stridor, we have barking cough, X-ray shows Steeple Sign, and AP view, and subglottis narrowing, all this. So let us understand them, what's happening here. So if you look at this, we're going to deal about this. A child has got a fever and stridor, and that means there is some problem with the airway. There is upper airway obstruction. So let us understand under this the infective causes of stridor, right? So infective causes. So under this we'll be dealing about two. One is Croup, and we'll just compare that to Epiglottis. So let us understand the first thing regarding the Croup. In this Croup, we should understand that 70% of laryngotracheal bronchitis. What do you mean by laryngotracheal bronchitis? It means that it is an inflammation of larynx, inflammation of trachea, and inflammation of bronchus. So we have a larynx, laryngotracheobronchitis, right? Laryngotracheobronchitis. So these are the important points we should understand regarding this meaning of laryngotracheobronchitis. So let us understand what's happening when there is an infection, viral infection, because 75% of these Croup, right? 75% of this Croup is because of this para-influenza. So let us understand what's happening in this para-influenza. Let us go with that. So when the para-influenza goes or attacks this trachea or larynx or bronchi, so the moment the virus attacks, so it leads to inflammation and edema of this trachea, larynx and bronchus. So that leads to upper airway obstruction, because initially you have a good amount of diameter. The moment after the obstruction, after the inflammation, edema, there will be an obstruction here. So that is the reason you have an upper airway obstruction. So now the air has to pass through this narrowed part, so there will be an increased resistance to airflow. So because of increased resistance to airflow, so there is increased intrathoracic negative pressure, right? There is increased intrathoracic negative pressure, and because of increased thoracic negative pressure, that leads to collapse of upper airway and there will be an respiratory failure. So ultimately we should understand that in these laryngotracheobronchitis, because of para-influenza, and that gonna disturb the trachea bronchi. So the moment it disturbs the trachea and bronchi, and that leads to edema, and that leads to narrowing of trachea and bronchus. So now the air has to pass against this or against this with the resistance, so that you have, there is increased intrathoracic negative pressure, and that leads to collapse of upper airway. That means the collapse of, it can be collapse of trachea, all that, and it leads to respiratory failure. So this is the mechanism what's happening in the Croup. So because of this, the air has to pass through the narrowed space. So you have a stridor. What do you mean by stridor? Stridor is nothing but is a high pitched whistling sound, most often heard while taking a breath, right? So because the air is passing through the narrowed space because of edema, so that is the reason you get a stridor. And the same reason, that is the reason you get a barking cough, as if you are barking, right? The cough, you can hear the cough as if you are barking here. And if you look at this X-ray, you have something known as steeple sign. And what do you mean by steeple sign? So let us understand how the steeple looks first, then we'll be looking into X-ray. So these have the steeple sign, these have the steeple looks. So the narrowed, the pointed, it is an upward pointed V shape here. So if you look at this, let us look at that in the X-ray. The same, if you look at this is the X-ray of a Croup or laryngotracheobronchitis, where there is a narrowing of this subglottis part, right? So you can look at this is a X-ray where you have got a narrowed part, the pointed structure. This is a subglottis part where there is a narrowing of the larynx, right? So that's all you have to understand regarding this. And this is a view of AP view. And this steeple sign is because of subglottis narrowing. What is the subglottis? In the sense, below the epiglottis where you have larynx, then comes the trachea. So this is known as steeple sign. So what will be the treatment here? The treatment will be the drug of choice for the mild Croup. So we have divided this Croup into mild Croup and moderate to severe Croup. In the mild Croup, we're gonna use, ultimately it's because of edema, right? So we're gonna reduce the edema, right? To reduce the edema, all this inflammatory substance, we're gonna use a dexamethasone. And remember that dexamethasone 0.6 milligrams per kg, and high dose we're gonna give, a single dose we're gonna give, right? If you look for the drug of choice for the moderate to severe Croup, and now the drug of choice will be nebulization with racemic epinephrine. So what do you mean by racemic epinephrine? It is nothing but it's the mixture of dextrose and levo isomerase of epinephrine, right? That's all you have to understand regarding this nebulization with this racemic epinephrine, right? So remember that all the treatment, ultimately our aim is to reduce the edema of airway, because you have an edema in the Croup. So our ultimate aim is to reduce the edema. So that's all you have to understand, guys, regarding this laryngotracheobronchitis, that is Croup. So let's go to the next one. The next will be the epiglottitis. So let me read the points written here. It's written that epiglottitis worldwide, the cause is what you have gotten, Streptococcus pneumoniae, Staph aureus, and you have Streptococcus pyogenes, right? So this pyogenes, pneumococcus, aureus, pneumoniae, aureus, all this, they cause the epiglottitis in the worldwide. But if they ask you epiglottitis, in India it is H influenza. So let us understand what do you mean by that. So to understand that, we have to look into the normal epiglottis, then we'll be going with what is epiglottis. So if you look at this is the normal, this is tongue, right? This is epiglottis, right? You got a larynx, all this trachea. So this is normal epiglottis. But because of bacterial infection, right? So because of infection, so it can be because of Staph aureus. So the moment the Staph aureus worldwide, and then you have got an pyogens or pneumonia, right? They're gonna affect, they're gonna cause the epiglottitis, right? So in India, if they ask you this epiglottitis, it is caused by H influenza, right? It is caused by Haemophilus influenza. So let us look in more prominent aspects. So this is a normal epiglottis which you look from the superior aspect, but after this, in this epiglottitis, there is an inflammation where you're gonna look or look at the epiglottis like this, right? This is how it looks. So let's go with the next thing. The next will be the X-ray. And how the X-ray of epiglottitis look? In this X-ray, it looks somewhat like a thumb sign is present, the lateral view. And it's also written that child may require emergency tracheostomy, and the treatment will be airway maintenance and ceftriaxone plus sulbactam, that is extended spectrum beta lactam. So let us understand this. So if you look at the X-ray of epiglottitis, and you can look at this is a lateral view where you can observe this is epiglottis. It is a thumb, right? Thumb. This is known as thumb sign because now the epiglottis look like a thumb because it has swollen up. So that is the reason we have thumb sign, right? If you look at the next point, the next thing written here is child may require emergency tracheostomy because now the air is not passing through this through the epiglottis into the trachea, into the larynx, into the trachea, then into the lungs ultimately. So ultimately what we need in the child, we're going to go with this emergency tracheostomy. So what do you mean by tracheostomy? Where we're going to make a hole at the trachea, right? So this can be done in the child, and this is known as emergency tracheostomy. So the child may require emergency tracheostomy. So what is the treatment for this epiglottitis? The treatment will be airway maintenance because now there is an edema, in the sense there is a inflammation of epiglottitis, so epiglottis, so that can decrease the entry of air, so you have to maintain the air. So that should be a important points. And now you got in for this old day for the staph bacteria, we're going to use this ceftriaxone, and we're going to use plus sulbactam. So why are we going to use sulbactam? Because sulbactam, it is an extended spectrum beta lactams that can cover the wide range of bacteria. So we're going to use this sulbactam. So that's all you have to understand, guys, regarding this Croup and other points. So we got a question given here. It's written that a 2-year child with brought to the emergency, and he has a barking cough. Remember, he has a barking cough, stridor, right? Stridor. And remember that only during crying, stridor only during crying. His hydration is normal. Respiratory rate is 36 per minute. His temperature is 39.6 degrees. His saturation is 96%. What will be your next step? So in the given question, in the given options, whether you have a racemic epinephrine nebulization is used, or high dose dexamethasone is used, or we're going to use nasal swab for influenza, respiratory syncytial virus, and antibiotics IV. So the answer will be high dose dexamethasone because it is a mild Croup, right? So these are the features where the 2 years child brought to the emergency, he has stridor only during the crying, and if you look at this, hydration is normal, so respiratory rate is fine 36, and you have a temperature fine, saturation 96, everything is fine. That means it's a mild Croup. So that for the mild Croup, we're gonna give the next step will be the high dose dexamethasone, right? So the other points like racemic, epinephrine, all that we'll be using for the severe, moderate to severe. So that's all, guys, we have to understand this. And how do you classify Croup? So we have a Croup, how do you classify Croup? So you have something known as Wesley Croup score criteria. Under this, you have a level of consciousness, normal, disoriented, cyanosis, none, cyanosis with anxiety, cyanosis at rest, stridor, none, stridor when anxiety, stridor at rest, air entry, normal, decreased, all this. So if you look at these, you have a different characteristic, you got in points at this aspect. But the thing we have to understand here is we're gonna grade the score here. If the score is less than or equal to 2, then this is mild Croup. If the score in these what Wesley Croup score, if this score is between the 3 to 5, and this is known as moderate Croup, and if the score is 6 to 11, and this is a severe Croup, right? So that's all you have to understand. Mild Croup, that is less than or equal to 2, moderate Croup 3 to 5, right? 3 to 5, and that this will be your moderate Croup, and if the score is 6 to 11, and this will be a severe Croup. And if you look at this, if the score is more than 12, that is impending failure, respiratory failure. So there is a respiratory failure. So this score helps in grading the groups. So that's all you have to understand, guys. So you got another question given here. It's given that a 6-year-old boy is brought to the emergency room with an history of, right? So 3 hours history of fever with 39.5 degrees, that is 103 Fahrenheit, and score, if you look at this, there is a sore throat. The child appears alert but anxious and toxic, and he has mild inspiratory stridor, and he has drooling and the saliva drools, and you should immediately. So what is the next step? And the given options, you have something known as examine the throat and obtain a culture, obtain an arterial blood gas and start IV line, order a chest x-ray and lateral view of the neck, prepare to establish an x-ray, sorry, not x-ray, it's airway. So if you look at this, in the given option, it's given that 6-year-old boy is brought to the emergency room with an history of fever, right? History of fever, and that is of fever 103 degrees centigrade Fahrenheit, so right, higher side, and there is sore throat, right? Remember, there is sore throat, and child appears alert with anxious and toxic. The child appears toxic, and he has mild inspiratory stridor, and remember that there is a drooling of saliva. So what should be your immediate? And immediate should be repair the establish the airway, because this is a case of epiglottitis. So in the next step, epiglottitis, where we have to maintain the airway, so the answer will be establish an airway. So that's all, guys, you have to understand here. So we have other points written here. It's written that you have something known as recurrent pneumonia, and under this it's written 2 episodes of radiographic pneumonia in 1 year or 3 episodes of any time frame. And it's also written that persistent pneumonia, that is persistence of symptoms and radiographic abnormalities for more than 1 month. And it's also written that recurrent pneumonia. So let us understand them here. So if you look at this, the first what do you mean by recurrent pneumonia? So we call it as recurrent pneumonia, that is pneumonia is nothing but it's an inflammation of lung, where in this recurrent pneumonia, when we call it as recurrent pneumonia, when 2 episodes of right, 2 episodes of radiographic pneumonia. What do you mean by radiographic pneumonia? That means if you have a patch on the x-ray, right, the opacities, the patches of consolidation, if you find on the x-rays, and 2 episodes of radiographic pneumonia in 1 year, or if you have a 3 episodes in any time, right? If you have a radiographic pneumonia, right, radiographic pneumonia in 1 year, 2 episodes, or 3 episodes in any time frame, so in such, this is known as a recurrent pneumonia, right? And if you look at the next points written here, it's written that we have a persistent pneumonia. So what do you mean by persistent pneumonia? Persistent pneumonia is nothing but persistence of symptoms and radiographic abnormalities for more than 1 month. So if you have this persistence of symptoms, either if you have a persistence of symptoms, normally pneumonia it should come to a normal before, right? So if the persistence of symptoms and radiographic abnormalities, if that continues more than 1 month, so the name itself tells it's a persistent, so it is a persistent pneumonia. So let us understand the next point written here. It's written that under this recurrent pneumonia, right? Under this we have a recurrent pneumonia. So what are the causes of recurrent pneumonia? So I told you that the recurrent pneumonia, there are 2 episodes of radiographic pneumonia in 1 year. So what are the causes of recurrent pneumonia? And the causes are left to right shunt. So what do you mean by left to right shunt? So it can be because of ventricular septal defect or atrial septal defect. So this is the left side of the heart, this is right side. The blood from the left ventricle can move into the right ventricle. From there it can go into the pulmonary artery. From there it goes to the lungs. So now the blood moves into more into the lungs. So they have chances of recurrent pneumonia in such and immunodeficiency patients where the infection can be recurrent, or if you have something known as a gastric esophageal reflex. And what do you mean by gastric esophageal reflex? That means the acid which is present in the stomach, now it is moving up because of some problem with the lower esophageal sphincter, so it can move up. From there it can go into the trachea. So if you have a gastric esophageal reflex, and that can also lead to a recurrent pneumonia. What is the gold standard for the gastric esophageal reflex? And the gold standard will be 24-hour pH monitoring. So what do you mean by 24-hour pH monitoring? So we're going to look for the pH or the acidic nature in the esophagus. So from morning we're going to look for that, and we're going to look for the 24 hours, right, AM to PM, right? We're going to look for that and observe. If you look at the pH, in the 24 hours, most of that it will be less than 4 pH. So now there will be less than 4 pH, and that tells that yes, there is a gastroesophageal reflex, because the acid which is present in the stomach, it is moving into the esophagus. So the moment you do 24 hours pH monitoring, so most of the time the pH gonna be less than 4 hours. So that's all you have to understand, guys, regarding this aspect, right? And if you look at the next point, it's written that cystic fibrosis, most common cause of recurrent pneumonia in the West, that is UK and Europe. In the UK and Europe, right, and the recurrent pneumonia, it is because of this cystic fibrosis. So now let us understand what is cystic fibrosis. So let me read the points written here. It's written that incidence 1 in 25, 2500 UK, chromosome 7q, and you have CFTR, that is, you have something known as C-camp regulated chloride channel, all this nonsense given. So let us understand this, guys. So let us understand first regarding the the pathophysiology, what's happening here. So we should understand one basic points. So what is that? So let me take, if this is a trachea, right, if this is lung, this is bronchus. So let me take this bronchiole out, and this is the bronchiole which I took, and these are the cells which are lining the bronchiole, right? So just remember, if these are the cells which are lining the bronchiole. So let me take one cell out. For that I have to take one cell out, and let me take this cell out. So you know that every cell has got a nucleus, and every cell has got a nucleus, and every nucleus has got a chromosomes. So if you look at this, now the chromosomes, right? So you have a gene, right? You have a gene known as CFTR gene. This CFTR gene, that codes for a channel. That means this gene undergoes transcription translation. So from the endoplasmic reticulum, ultimately you have a channel, normally the chloride channel, that go and settle on this membrane. So right now you have a chloride channel because of this CFTR. That means that codes for the chloride channels. So now the chloride channel is prepared. So there is, and I'm speaking about the normal first. Now you have a chloride channels. So what happens normally? This chloride channels, right, allows the movement of chloride into the space. So you can look at this, the movement of chloride into the bronchioles, right? What happens? You have a mucus at this aspect, right? You got a mucus here. Now this chloride channel, which is formed from this CFTR gene, right? And now there is efflux of chloride. Right now you got a lots of chloride which is present in this bronchiole, right, in the mucus. Because of this chloride, what happens? This chloride traps water in the mucus, right? It traps the water. Now because the water is present, right now you got a lot water which is present in the mucus. So the mucus can be expelled easily, because this mucus right now it's not thick. Why it is not thick? Because after the efflux of chloride into this mucus, there is movement of, because you have a negativity present here, so there is water moves into this mucus, because you have a negative accumulated at this aspect. So water moves into the mucus. So the viscid mucus now becomes liquid, so that the person or the baby can expel this mucus out through the ciliary actions. This is a normal mechanism, what's happening in the normal persons. But what happens in the cystic fibrosis is, because of mutation in CFTR gene, which codes for the chloride, because of this mutation, now there is some problem related to the chloride channel. So either there can be a problem where the chloride channel which is formed in the endoplasmic reticulum, they are not moving to the cell membrane, or there is a problem related to the chloride channel itself at the cell membrane. So what happens if there is a problem with the chloride channels? Suppose if this is the cell which is present here, now the chloride is not moving out, so there will be a lot of accumulation of chloride in the cell itself. So because of increased negativity in the cell, now the sodium moves inside. So when the sodium moves, even the water also moves inside, right? So what happens now, you got a less water present in this bronchus, in the mucus. So now this mucus becomes thick, right? This mucus becomes thick, and this thick mucus blocks this bronchi, right? And they are not expelled out. This is the basic mechanism which tells us why there is thick mucus either in the intestine, either in the pancreatic duct, either in the bronchioles. So that's all you have to understand regarding the pathophysiology. We just understand that you have a gene known as CFTR gene that normally produces or chloride channels that helps in the efflux of chloride. So the chloride moves out normally, so there will be entry of water into the mucus. So now the mucus becomes thin. But what happens in this CFTR mutation, that is cystic fibrosis, the chloride cannot move from the cell into these bronchioles. So there will be an accumulation of chloride which is present in the cell. So what happens, there will be an entry of water, entry of sodium in the cells. So this mucus becomes thick, is what we said, and thick, so it cannot expelled out, and that's gonna block this bronchioles. So that's all it's written here regarding this mechanism where there is efflux of chloride out, right? You got an efflux of chloride, so you got a thickness, a normal, the bronchioles, right, that moves, right? So that's all you have to understand here. But if you look at this, there is a block or there is some problem with these chloride channels, right? There is a problem with this. So the chloride do not move into the bronchioles. So now there will be no water and the mucus becomes thick. That's all, guys. We have to understand the basic concepts. So let us understand that. Right now you know the basic concepts. So let me read this first. So which of the following statement about cystic fibrosis is not true? It is an autosomal recessive disorder. Yes, this is true answer, because this cystic fibrosis is an autosomal recessive. You need 2 copies for the development of cystic fibrosis, because this is an autosomal recessive. And if you look at this mutation in cystic fibrosis, because in cystic fibrosis is because of CFTR. Yes, it's right answer. Abnormality in CFTR which lead to defective calcium transport, and this is false. This is wrong answer. It's not a calcium transport, and this should be chloride transport. So that's all, guys, we have to understand here. So let us understand the next point written here. It's written that this cystic fibrosis, the same mechanism which forming at this aspect, the same mechanism, it's going to affect the different parts of the body, right? It can affect the different parts. So I told you that I took the example of respiratory, where there is accumulation of mucus, right, in the bronchus. So there's a block here. So in suppose, say example, if this is the bronchiole, right, and you got a mucus present here. Now right now the thick mucus do not move out. So you can see this is accumulation of thick mucus here. So this can lead to what happens, that can lead to growth of bacteria, right? Because the mucus is not expelled, so this mucus contains a bacteria, and that can lead to a pneumonia. So more than 5 years children's, most common presentation in cystic fibrosis in more than 5 years children, and that will be pneumonia. In less than 5 years babies, right, less than 5 years, the bacteria which is which affects this or which affect the cystic fibrosis persons, and that will be Staph aureus and Haemophilus influenza. And 5 to 18 years, Staph aureus and Pseudomonas. And if you look at these, in the more than 5 years babies, Pseudomonas mucoid is more prominent as compared more than Pseudomonas non-mucoid. But just understand that this cystic fibrosis, it affects a different system, but it's gonna affect the respiratory, where it causes pneumonia, right? Where it causes pneumonia, and this pneumonia is the most common presentation in cystic fibrosis in more than 5 years. So in the age less than 5 years, this bacteria, Staph aureus, and influenza, Haemophilus influenza, the virus, so that can lead to that can cause the problem in this cystic fibrosis. In the 5 to 18 years, babies or children's or the persons is affected with cystic or no, sorry, Staph aureus and Pseudomonas, right? So these are the important points, guys, we have to understand. And more than 5 years, children, they are more prone for the Pseudomonas, and the mucoid Pseudomonas are more common as compared to the Pseudomonas non-mucoid. So that's all you have to understand, guys, regarding these aspects. So let's go with the next one. The next will be a most common organism associated with cystic fibrosis will be Pseudomonas aeruginosa. And this Pseudomonas aeruginosa, and this is a non-mucoid strain. That is, the Pseudomonas mucoid is greater than a non-mucoid. So just understand that most common organism associated with cystic fibrosis, if they ask you, and that will be answer should be Pseudomonas aeruginosa, right? So that's all we have to understand here. And the next question is given that cystic fibrosis Pseudomonas very high in female. So if you look at this, and the females have more prone for the Pseudomonas with the cystic fibrosis, because this incidence increases because in females you got an increase of presence of estrogen. So you have the Pseudomonas, you can find more often there. So what is the antibiotics we're going to use for these Pseudomonas? We have anti-pseudomonal antibiotics, where under this we have something known as ceftazidime and cefaparazone and piperacillin and ticarcillin, right? So these are the drugs which are used for the anti-pseudomonas. So what are those? So those will be ticarcillin, right? Ticarcillin, and you can see this piperacillin, right? Piperacillin, and you have cefoperazone, right? Ceftazidime. So just remember that cefoperazone and piperacillin, right? And you have ticarcillin. So these are the antibiotics which are used for the Pseudomonas. So we have other antibiotics used here, like inhaled antibiotics for the bacteria. We can use tubramycin, and we can use azithromycin, and we can use colistin, we can use ciproflox, amikacin, levofloxacin. So these are the antibiotics, inhaled antibiotics we're gonna use, right? So that's all you have to understand. And if you look at the next point written here, it's written that we have a bacteria known as Burkholderia cypressa, right? And this is that accounts about 2.5%, and this is rare, and this is specific, and this is a fatal condition. If the children are affected with these Burkholderia, and this is a fatal conditions, right? And if you look at the next point, the next will be we have something known as Acromonas, right? Acrobacter. So you can look at this Acromobacter that comes under this is an Aeromonas. This is seen only in these airways, so let's not understand this. So just understand that even this Acromobacter also causes. So that's all, guys, we have to understand regarding this aspect, the pneumonia which is causing all these questions. And if that affects this cystic fibrosis can also affect the pancreas. So once it affects the pancreas, that's gonna block the pancreatic duct. So if it blocks the pancreatic duct, these lipase enzymes do not come out into the intestine, and they do not break the fat. So you have a question given here. You have less than 5 years baby, if you have a foul smelling, bulky stools, and that tells you there is steatorrhea, right? So that's all you have to understand. Most common lethal genetic disorder will be, it is a most common lethal genetic disorder in the Caucasians, right, is cystic fibrosis. So if you look at this, what in this cystic fibrosis, it is the most common lethal, right? What is lethal, right? Lethal genetic disorder is in Caucasians is cystic fibrosis, right? So that's all you have to understand, guys. It's nothing but it's dangerous. So next will be the other aspects. So you have a question given here. A 1-year-old girl presents with a fever since 24 hours, and that is on and off. There is on and off coughing. She is passing foul smelling, and she has foul smelling bulky stools. She is passing this, and she had 4 attacks of bronchitis in the past, and the girl is suspected of, since it is a foul smelling bulky stool, so it can be cause of cystic fibrosis, where the bulky stools, all this, it's because of steatoria, right? So that's all you have to understand, guys. This cystic fibrosis, since it can it blocks the pancreas, so the insulin which is produced, it can block the exocrine ducts, so the insulin which is produced in the pancreas do not come out, so that can lead to insulin dependent diabetes mellitus after 35 years of age in 25%. And if in the GIT, it causes meconium ileus. So what is this? So there is a distal intestinal obstruction, the same mechanism where you have a thick mucus present, meconium, which is present in the intestine. Since it is very thick, it is not passed, it is blocking the intestine. So this is known as distal intestinal obstruction, the same mechanism happening here, meconium ileus, right? So that's what it is common in who have a past history of meconium ileus, right? And this distal intestinal obstruction is common in the persons who have a past history of meconium ileus, and this occurs in older children with cystic fibrosis. And if you look at the next question, the next will be a 48-year-old baby has not passed meconium. What is the next investigation to be done? So the baby has not passed meconium. So if you look at the options, are we gonna do the CFTR gene test or sweat chloride, manometry, lower GI contrast study? So answer will be lower GI contrast study, because we're gonna look, we have a different problems why there is meconium, it's not, baby is not passing meconium. So we're gonna look for this lower GI contrast study. Why are we gonna use this contrast study? We're gonna use this because it can be, we can look for the we can visualize the distal part of intestine. So it is used for diagnostic, and it is also used for the therapeutic because it can flush out the meconium. So that's all you have to understand. The lower GI contrast study is the next investigation to be done. So this, since cystic fibrosis, it can affect even the vas difference. So once it affects it's gonna block in the vas difference. So you gotta have an azoospermia, right? And that can also happen. These babies can have a nasal polyp. So if you look at the next point written here, it's written that absent vas difference, it is seen in 40% children of cystic fibrosis, right? If you look at the next question written here, it's written that a 40-year male presents with primary infertility. His testes are normal shaped, but the vas difference are not palpable, right? And if you look for the semen analysis reveals azoospermia, right? Reveals azoospermia, and there is a detailed examination shows low volume, low pH, high viscosity, and high liquefaction time. Which of the following is most likely cause? If you look at these in the given options, the vas difference is not palpable and azoospermia. So the given options: CFTR mutation, estrogen receptors. So you have an estrogen receptor mutation, varicocele hyperprolactinemia. So the given answer will be CFTR, because we have in different aspects: vas difference not palpable, azoospermia seen here. And if you look at this detailed examination shows low volume, low pH, high viscosity, right? It has got a high viscosity here, so that tells you there is CFTR mutation. So if you look at the next point, it's written that most common mutation in cystic fibrosis is delta F508 mutation. This is seen in 70% Caucasians, 25 to 30% in Indian children of delta. So let us understand what is it trying to tell us. So if you look at this, you have a protein, right? I have told you that you have an what the channel, that is chloride channel, and this chloride channel approximately it has some 1000 amino acids. So out of 1000 amino acids, the 508 amino acid is mutated. That means you have it at the 508 amino acid is phenylalanine, right? It is a phenylalanine. So this phenylalanine, F for phenylalanine, which is present at the 508 position of amino acid in this chloride is mutated. Because of this mutation, this chloride channel is misfolded. It is misfolded. It's not doing its function. And remember that, if you look at this aspect here, that it is, that's what it's written, that delta F, F for phenylalanine amino acid, 508 is the position or 508 amino acid in this chloride channel. So this is seen in 70% of Caucasians, and it's seen in 25 to 30% of Indian children, right? And single gene CFTR has 1800 mutations, right? So it has got an 1800 mutations, and it's also written that if you look at this aspect, what delta, what is that? Yes. So delta F508 test does not exclude. So it does not exclude 65. Suppose if there is no delta F508 mutation, and it does not exclude cystic fibrosis. It can be other causes also, but the major is this most common mutation is delta F508. So if you look at the next point written here, it's written that how many nucleotide deletion, how many nucleotides are deleted in 5F508 mutation, and the 3 nucleotides are deleted in cystic fibrosis, and that I told you that, and the amino acid is phenylalanine, that is TTT, right? So just remember how many nucleotides, and your answer should be 3 nucleotides. That's what it's written, that delta F508 deletion, it is what, right? It is 3 nucleotide deletion. It results in loss of amino acid phenylalanine F at the 508 position of protein. So if you look at the next point, it's written that delta F508 class 2 mutation, right? CFTR protein is created. So when you have a mutation here, the protein CFTR protein that has gotten that protein is now which is formed is misfolded. So that is the reason, once the protein is misfolded, the protein normally should come from the endoplasmic reticulum, right? Normally it should come from the endoplasmic reticulum to the cell membrane. So this is known as trafficking. So because of misfolded proteins, this protein is not moving to the cell membrane. So this is known as trafficking defect, right? So it's not reaching the cell surface. So that's all you have to understand. And what is the drug we're gonna use? We're gonna use a drug known as ifacaftor, and you have something known as lumacaftor. So just remember that it is CAFTR. So CAFT, just remember that we have CFTR gene, right? You can just remember CFTR drug, Caftor. And what does it do? The CFTR, this is a drug where it opens the chloride channels. So it opens the chloride channels, so now the chloride can move out. Plus we're gonna give even this lumacaftor. What does it do? It corrects drug, but you have something known as CFTR trafficking. So it moves this protein to the cell membrane. So this is how it is used here. And remember that transport and traffic trail, this combination improves the FEV1. So you know that FEV1 is the first air amount of air exhaled in the first second. The moment after you give these drugs, these two drugs, that is ifacaftor and lumacaftor, and this improves the FEV1. So that's all you have to understand, guys. Diagnostic criteria for cystic fibrosis. So what is the diagnostic criteria for cystic fibrosis? So the sweat chloride, if it is more than 60 milli equivalent per liter on 2 occasions, normally it should be 4. So if you observe carefully, right, and remember that in the normal which we spoke, where the chloride is inside the cell and that should come out. But this is opposite in sweat gland, where lots of chlorides are present here, right? So because of this block, the chloride do not move into the cell. So there will be an excess of chloride accumulate in the sweat gland. So that's why sweat chloride more than 60 milli equivalent per liter on 2 occasions. Normally it should be less than 40 milli equivalents. and this tells you the diagnostic criteria for cystic fibrosis, or you should have a two known CFTR mutation. So one we know that is delta F508, and if you have known CFTR mutation, then also tells us yes, the baby has a cystic fibrosis. And the best test for this cystic fibrosis will be a diagnostic nasal electrode potential difference. So if you look at this given question, it's given that a child presents with the raised chloride 32 milliequivalent per liter and 42 milliequivalent per liter and suspicion of cystic fibrosis, and which other test would you do to exclude the diagnosis of cystic fibrosis? So we're gonna do nasal electrode potential difference, right? So because if you look at the given question, the child presents with a raised chloride 32 milliequivalent per liter and 42 milliequivalent per liter, and there is a suspicion of cystic fibrosis. So go for the nasal electrode potential difference for the diagnosis of cystic fibrosis, and this is the best method. So let's go with the next one. The next will be it's given that the given question, and baby with Down syndrome, right? Baby with Down syndrome and recurrent pneumonia, and you have under the barium swallow, esophagus shows aberrant right subclavian artery, and that compresses the esophagus. So what is his answer? The answer is dysphagia luceria. So let us understand what is this here. So if you look at this, this is the normal where we have got a esophagus, you have a trachea, this is an aorta where we have this is a subclavian common carotid, it's fine. But if you observe carefully here, right, this is the left side, the right side of the subclavian is winded around this esophagus, so it is compressing the esophagus. So that is the reason you have a difficulty in swallowing, right? So that's what it's written, a baby with Down syndrome with the recurrent pneumonia, and in the barium swallow, esophagus shows an aberrant right esophagus artery compressing esophagus, and the answer will be dysphagia because you have an right subclavian artery which is winding around the esophagus, so there is swallowing problem. So this is known as dysphagia luceria, or the vascular ring. So that's all guys you have to understand. And then the next question, an 18 months boy, recurrent pneumonia with feeding difficulties and choking, barium swallow shows H-type rare, you have got a fistula, H-type tracheoesophageal fistula. What is the investigation of choice for the H-type tracheoesophageal fistula? Right, with tracheobronchomalacia, and the answer will be tracheobronchoscopy. Why it is tracheobronchoscopy? Why are we going to look for the bronchoscopy? Because in bronchoscopy shows another opening before trachea bifurcates, right? So because they in the H shape, so if you look at the H-shaped tracheoesophageal fistula, this is an H-shaped tracheoesophageal fistula where the esophagus gets connected to the trachea. So the acid from the stomach can move out into the esophagus into the trachea, and there can be a perforation. So that is the reason there can be a tracheomalacia. What is tracheomalacia? Tracheomalacia is nothing but there is a flaccid tracheal cartilage, there will be a collapse. So because of acid aspiration, so that is the reason we're going to go with the investigation of tracheobronchoscopy. So that's all guys we have to understand. If you look at the next point written here, it's written that a 4-year-old baby with a history of tracheoesophageal fistula repair at birth and is evaluated for the chronic cough. The cough has persistent since he was discharged from the hospital. After tracheoesophageal repair, the cough is dry and barking and occasionally associated with expiratory wheezing. The most likely cause of chronic cough in these patients, and this can be because of secondary tracheobronchomalacia, right? So this can be the answer, secondary tracheobronchomalacia, because of the aspiration of the fluid into the trachea. So because of tracheoesophageal fistula repair, right? He had a tracheoesophageal fistula before, so it can be that cause. And the next question given here, it's written that a previously healthy 2-year-old girl is given oral antibiotic therapy for the cough, fever and patchy consolidation of the right lower lobe. No crackles heard on the chest auscultation. And if you look at this fever, the cough improves, but on the follow-up chest radiographies at 8th week demonstrate there is a persistent consolidation involving the right lower lobe. Next step is the evaluation. So what are we going to do? And that can be, we're going to go with the bronchoscopy and bronchoalveolar lavage, right? So to look at that, what's happening there. So that's all regarding the respiratory, guys. That's all for now. In the next session, we'll be dealing about the other concepts. Thank you.